when you think about your step two timeline, it obviously like will depend on your rotations and kind of like your comfort, how comfortable you are kind of with the level you studied. But most students will take the exam in about a year from now, right? So like, I had students in the class above you who were taking the exam November, December now, and then they'll go into February, March, right? Even beyond if needed. The big thing, I don't care when you guys take the exam. It truly does not matter. You take the exam when you're ready, and we'll kind of talk about how you know you're ready. I think the big thing is trying to get step two done before you start doing your sub I's and away rotations if you decide to do those. So really, like there's no time crunch. MCW might have a time crunch by saying like, hey, you need it done by this month. So obviously get it done. But truly, I think you guys should spend as much time studying and feeling comfortable in this material as possible because this brings up it's the backbone of everything, right? Regardless of what field of medicine you go into. So just as long as you have your materials done, you have step two done, passed by your sub I's and aways. So that way you go into your sub I's and aways knowing a little bit of medicine, right? But also you have that off your plate. So then you can just fully like envelop yourself into whatever rotation you're on. And then on the flip side, right? So there's a pro of, waiting to take step, like just pushing it off, waiting until you score that perfect score. But at the same time, if you're scoring a decent amount and you take that exam earlier, that gives you more time to start studying the materials you want to study, right? So like I took step like April 4th, I took step two. I started doing my IM sub I's and away rotations. They all started early June. That gave me from April to June to just study like advanced IM concepts. And it's something like I'm still studying today. I'm reading textbooks, doing like IM board certification questions, etc. To kind of prepare myself for these intense rotations and then residency, right? So like whatever like rotation or field of medicine you want to go into, the sooner you can get done with step two, the sooner you can start reading up on all those, unique guidelines, unique procedures, interesting medical facts that you might need to know, to be impressive on your sub I and obviously to build yourself as the kind of physician you want to be. So it's like that balancing act. And without even getting into studying, everyone has a goal score in mind when they take step two. Obviously, like with step two having a score, step one not being scored anymore, like the score does matter. It will matter more if you want to do things like opto, derm, anesthesia, like neurosurge, ortho, like those kind of things. It matters less if you want to do more like family med, peds, IM, etc. Um, at the end of the day, like your score does matter because it'll get your foot into the door, but it's surely not like the only thing that matters. Some of these programs will screen you by your score, just like they use the MCAT. And like quite frankly, those aren't the kind of programs I want to go to, right? If you're interested in those kind of programs, or anyone watching it, sure, by all means. If a score is just, or if a school or a program is just going to look at me based on my score and think I'm an acceptable candidate, like that's not the kind of program I want. Um, so again, like in my opinion, like I can teach anyone medicine. I can't teach you like how to work hard, the discipline, some of those intangibles. So those are the things you can bring to a residency program, regardless of your score. So make sure like you guys like during the next year and a half, like while you're getting ready on these rotations and then getting ready to do your residency interviews, down the road, you have other things on your resume that you can speak about. Okay. And we can kind of circle back to that. Um, how does all that sound so far? Like, I mean, as nothing new. Like the step two score does matter. And I honestly I think it's backwards in a sense. Like, they have like the ortho, neurosurge, derm, anesthesia, like optho, like those are the fields of medicine. If you want to match into, you need a score, like a 260 plus in a lot of those to like be competitive. And whereas like peds, family med, IM, less so. And I think that's completely backwards. Like when you think about it, like I want my internists, my PCPs, my pediatricians, like they should know the most amount of medicine. Like they should have the biggest breadth of medicine. I feel like those are the people that should be scoring the highest on these exams. Because when you think about like take neurosurgery for example, like they could score a 270 plus on this exam. The minute they take step three and they're done with like general medicine, they will become an expert in neurosurgery. You ask them to go auscultate someone's heart and put it together in a clinical picture based on them having JVD, peripheral edema, and these labs, or would they be able to tell me like what's going on? Probably not, because they're not thinking about that. That's just like a story for another day, but it's kind of interesting the way medicine has gone with these scores. Um, all right, so with regards to studying, right, the big thing you guys want to know about, the thing you guys have to understand is when you're on rotations, your time is no longer yours. It's completely different from your step one land and your first year and a half of medicine, right? So you guys all had your unique schedule where you could get up whatever time you wanted, you could watch your recorded lectures whenever, and then you had to be at anatomy lab or your good doctor course or whatever for like a few times every week or whatever. But at the most part, hey, if you wanted to watch your lectures at midnight, by all means. If you wanted to get up at 3 a.m. and start your day, by all means. When you're on rotations, that is no longer the case, right? For my people who are starting, IM wards, or you're starting on the wards in some way. So that'll be like if you're doing like inpatient psych, inpatient pediatrics, inpatient IM. You guys aren't at the point where you do electives, but like electives could be that too. Most of those clerkships will start, you'll have to report around 6:30, 7 a.m. It kind of depends on the senior resident and the attending. Whereas like your surgical rotations, again, depending on your clerkship, like which field of surgery you're in, you might have to show up as early as 5, if not even earlier sometimes. Sometimes a little bit later, right? It just depends on your schedule. And a lot of the times you're staying quite late. In general, your ambulatory blocks tend to be the least like aggressive in terms of schedules, right? Like I've talked to some of you guys who like family med, you guys are in the clinic like twice a week, right? And then you got like 2.5, 3 days off, and things along those lines. Whereas like, IM and surgery, you're gonna you should expect to like be doing something 6 days a week. Um, Most of those clerkships, you're on 6 days, you're off 1 day. Obviously, it's very clerkship dependent. It's very senior resident dependent and attending dependent. I've had senior residents who are like, medical students should never have to come in on the weekend. Don't come in. And I've had senior residents say, hey, as long as I'm here, you're going to be here, right? So it just kind of depends. But big things, right? Is, you are going to be expected to be in the hospital or in the clinic for a certain period of time. So with that being said, you no longer have time to do 1,000 Anki cards and practice questions and watch a million videos and do pathoma and all that, right? You're going to have to be very particular about how you spend your time. So with that being said, in general, right, there's a hierarchy of how you can learn the stuff for step 2, step 3, and beyond, right, for the rest of your life. Seeing patients, number 1, okay? Easy, right? I see it in person. It's going to stick a lot better than doing a practice question. It's going to stick a lot better than watching a video. It's going to stick a lot better than doing flashcards. Okay. Let's take, for instance, like you guys are on internal medicine. You get a patient who is admitted with dyspnea. They've got new peripheral edema. They have elevated JVD. You end up diagnosing them with an acute heart failure exacerbation, right? And maybe you guys have read about it. You surely know about it because you passed your step 1 exam. You could probably tell me everything you need to know about the physiology and pathophys, right? Even you could look at your notes. I don't really care. But how much would you be able to tell me about the diagnosis and management? Like, hey, if this was a brand new patient, how do we diagnose them with heart failure, right? If they're admitted to the hospital, what drug do I give, right? Do I give furosemide? Do I give bumetanide, torsemide? Do I give them a thiazide? How much do I give, right? Those things you're probably not expected to know, right? That's the whole purpose of these 3rd and 4th year rotations, is you're supposed to learn. But watch how, if you're really invested in your patients and you're watching how the attending is doing the workup, how the senior residents are doing the workup, you're playing a role in the workup and you're asking your senior resident and attending, hey, why did we choose this instead of this, right? You're asking the right questions. Like we are at a teaching hospital. Whatever hospital you're at, even if it's not Freighter, it is a teaching hospital. Those residents, fellows, and attendings are working at a teaching hospital for a reason. They want to teach, right? So obviously wait until it's not like super busy, and like no one's dying. But if you have a question on something, ask, right? Like I got so much out of asking the attendings, like, hey, why did you ask these set of questions in order to this set of labs instead of doing this, right? Like just doing that. Um, and then your biggest resource, right, when you don't want to be a nuisance and you want to learn more on your own, is going to be something called open evidence, right? Have you guys heard of open evidence? Open evidence, it's going to be free for medical students. You just have to put in your information. But this is by far the best piece of advice like I could give you guys for like doing well on rotations. Open evidence, you ask any medical question, it'll pull, it's an AI generated response and it will pull the medical literature. Um, and so I primarily use open evidence to help me with my plans. Okay. So like if we are able to diagnose a patient with congestive heart failure, I was like, okay, this patient presented with acute decompensated heart failure. What should my management plan be? Right. And it pulls out, you should do this at this dose, this at this dose, this at this dose. I can put that in my note. I can bring that up on rounds and we'll see what the attending says, right? The attending might say, oh, that's pretty close. Let's just do this or this, or hey, that's good. Or hey, you were way off the mark, right? And then you kind of figure out why. Where's the disconnect, right? But open evidence by far, that's how you learn on the fly. Is you're literally reading what do the guidelines say, right? And that's what step 2 is going to ask you about, right? Is a patient presents with an acute aortic dissection, right? You obviously will have to read the vignette and be like, yep, that sounds like aortic dissection. If I don't know how to treat it, right, ask open evidence, right? Even if you get a patient in real life, even better because it will stick better. But just like playing with open evidence and like whenever you guys come across a new medical topic or a new disease that you might not be familiar with the treatment, just putting that into open evidence and getting, a real quick synopsis will really help. But obviously, seeing patients in real life is going to stick better. You see, like when you're on IM wards, you're going to see heart failure, cirrhosis, CKD, COPD, pneumonia a million times. You guys will get really good at the workups and the treatment of those, right? The problem is you're not going to be able to see everything, and you're not going to be able to see everything multiple times to get it to stick, right? That's why attendings, you can watch them work up the same problem as you, and the attendings can do it in 5 seconds, right? They're like, patient presents with this, 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 it's this. Let me get these tests, and then we'll go from there, right? Whereas you, as a third year medical student, it might take you 30 minutes to an hour to think through the exact same problem, right? It's because the attending has seen this so many times, it's like muscle memory for them. Um, so, and I think like in general, step 2 is a lot easier to study for because of this, right? Because you get the concrete examples in real life, and it's testing you more on diagnosis and management, which is more concrete. Whereas step 1 is testing you more on like these like really small details of like physiology pathophys. Like you're supposed to like, when you think about like DKA or like things along those lines, like how are you supposed to visualize insulin resistance and things along those lines, right? Or like insulin deficiency in terms of DKA. It's really hard to like wrap your mind around. Whereas in real life, if you see a patient presenting in DKA, you see the really low bicarb, the expanded anion gap, you see an elevated beta hydroxybutyrate, you see these Kussmaul signs, and then you see how do we treat the patient and how do we see if they're getting better. That sticks a lot better. It's a lot easier to answer that question on step 2 than it is on step 1. I think in general, like the step 2 exam, it's harder because it covers a lot more information, but it's easier to study for because of that, because of it being more concrete. And then it's easier to study for because you guys have already done step 1 once. So you've already done like a prep for this. You've already built a really good foundation. You know what goes into prepping for a big exam like this. So that's what makes it like overall more manageable. Um, but yeah, so again, seeing patients first and foremost, asking questions, ask your senior residents, your attendings why, ask open evidence why. You can use ChatGPT as well. I use ChatGPT more for like my assessments. I never, ever, ever, and you should never, ever, ever have ChatGPT or open evidence write an assessment for you. Your assessment is how you learn as a medical student, right? I will send you guys an example note. I've sent it to like quite a few students because I know you guys have had practice writing SOAP notes, but doing it on like either a fake patient or you're in your clinical apprenticeship and you're like who the hell cares is a lot different than when you're a third year medical student who is getting evaluated every single day and you really care about your notes and you're trying to develop your medical reasoning skills. You should have been doing that from the start, and I know you guys were. But I get it. Like you run into the problem where you're like a first year medical student. You're like, I have no idea what's going on. How am I supposed to write like a good note? Um, with regards to that, right? So I'll send you like an example note, but doing notes actually will help your clinical reasoning and will help so much on step 2 and beyond, because it helps you formulate what is going on. It makes you put it into words. So you usually write like just a brief on soap notes. If it's a brand new patient, so like on ambulatory, all your patients will be brand new, right? Like it's a new visit. So you write like a full HPI, you put in their vitals, right? You put in their physical exam findings, and then you do your assessment and your plan. Um, your assessment, you usually start it with a few sentences overlying the problem, right? 56-year-old male presenting with acute epigastric pain radiating to the back, recently had a large amount of alcohol last night, right? And then I would finish that overall assessment like overall concerning for pancreatitis, we'll evaluate further, right? So then what I do is in your plan section, you break it down by problems, right? I don't know if you guys have seen this, but you do like hashtags, okay? You'll see it on your first day. You just do hashtags for your problem. So let's say this patient presented with his major chief complaint was abdominal pain, right? You do the good history, you find out it's epigastric, it's radiated to the back, it started last night, right? So I would try to be as specific as possible, and my first problem would be acute epigastric pain, right? And then I would write underneath that just a few sentences, right? Like acute epigastric pain started last night. Patient had a binge of alcohol. Has never had this happen before. And then we'll say like lipase in the ED was 5 times the upper limit of normal. This satisfies the Atlanta criteria for acute pancreatitis. Will admit to medicine and blah blah blah, right? Then let's say the patient has a history of hypertension and hyperlipidemia. Those would be separate problems, okay? But now, what if the patient, you get his labs back and you see he has hypocalcemia and he has an elevated hematocrit, right? He's got polycythemia. And you're looking at it, and maybe he has an elevated BUN too. And you're looking at all that and you're like, I could put hypocalcemia as its own problem. I could put elevated hematocrit, right? This would be an example of secondary elevated hematocrit, so secondary polycythemia. We'd have to do a little bit more investigation and get EPO levels and things like that, but story for another day. But you could put elevated hematocrit and elevated BUN all as separate problems, okay? And as a third-year medical student, that's not a problem. That's not a bad thing. But as you get better at being a physician, right, you get more medical knowledge, you'll be able to see, okay, this patient has acute pancreatitis. Can I connect the epigastric pain, the pancreatitis, with hypocalcemia, elevated hematocrit, and elevated BUN? You bet you I can, right? So the fat that's getting broken out from the pancreas can saponificate the calcium, right, and lower the calcium. The elevated hematocrit and BUN tells me my patient is likely dehydrated, intravascular dehydrated via third spacing from this inflammatory condition, right? So, to a second or third year medical student, you might see those all as different problems. But for someone who's like more like your attendings, your senior residents, or advanced medical students, you can see those all fit together. And so I would do my first problem would be acute epigastric pain, elevated lipase, concerning for pancreatitis. That would be my first line. Right underneath that, I would do hashtag hypocalcemia. Underneath that, hashtag elevated hematocrit. Underneath that, hashtag BUN, like just like Twitter, right? Hashtags. And so with that, then that's one problem. Those like what is that? That would be 4 hashtags. All make up one problem because it's all stemming from pancreatitis. Do you guys see that? How I'm doing that? And again, I'll send you guys an example note that I wrote. It's that patient whose note I chose to like send out to you guys. There's no PHI or anything, so you can't like identify the patient. He was a very complex patient, so the note is very in depth, but I think it helps you see how you can really work through these problems. So by seeing patients and working through notes constantly every day, you will gain so much appreciation for medicine and how things interact, right? This is what I've been trying to teach you guys from day one when we first started meeting, is seeing how the different systems, how the different symptoms all integrate into different clinical problems, right? So starting to work on your notes and seeing patients will stick the best, right? Okay, so those are notes and seeing patients, right? The next best thing is doing practice questions, okay? With regards to practice questions for step 2, the more the better, right? It's not a surprise. I'm not going to tell you anything different than I haven't told you since day 1. Practice questions are king, okay? With regards to practice questions, you can't just put your head down and do a million practice questions. I want you to do a million practice questions, but you have to understand the content of the questions, okay? And when you're starting off for step 2 land, these questions are going to be insanely hard. I'm telling you right off the bat. There is such a big learning curve, right? Because again, let me give you an example. You guys are gangsters at the step 1 stuff. You could read a step 1 question and it's like the same exact vignette, right? Or gentleman with acute epigastric pain radiating to the back, history of alcohol use, and a step 1 question would ask you, what's the pathophys? And you look for the answer about acinar destruction, release of the zymogens from the pancreas, and inflammatory destruction, right? Or they'd ask you about etiology, right? You'd look for alcohol, gallstones, triglycerides, infections, you look for drugs, etc., right? All the different causes. Okay, easy. But now for step 2, your question is going to be maybe the exact same vignette, but now they're going to ask you, how do I confirm the diagnosis, or what is the diagnosis, or what's the next step in management? And you're going to sit there and you'll be like, holy shit, I've never thought about how do I manage pancreatitis, right? And you're probably going to get that question wrong, okay? That is the whole purpose of these question banks. They are a learning tool. I never, ever, ever use UWorld, Amboss, and all these other things I'm going to teach you to gauge my progress, okay? The ways I gauge my progress are using MBME materials and seeing how confident I feel in the clinic, right, or in the wards, okay? And we'll talk about that. But UWorld, Amboss, and all these other things I'm going to talk about briefly should all be used as a learning tool, right? So you get this question on pancreatitis, you're like, I have no idea, right? You end up getting the answer wrong, and your job as a learning student, you read the answer explanation, and then in like a sentence or two, why is the right answer right? Why are the wrong answers wrong? Okay, not just the answer I picked, but if you want to be the best, you kind of go through all of the different answer options that are wrong. And if you can just summarize in a sentence or two why they're all wrong, right? Then you have a good understanding, okay? And so by going through all the different answer options, you can just be like, okay, what would have made this answer option true, right? Like I love the questions where they're like, patient has infective endocarditis, right? Or like they're asking what's the diagnosis, and one of the options is infective endocarditis, but there's no murmur and there's no fever in this patient, right? That makes infective endocarditis highly unlikely, okay? So that would be like my one-liner. So if you can do that, you have a decent grasp on the concept, okay? And then UWorld does a good job. It has educational objectives. It gives you one sentence. What were we testing you on, right? Treatment for acute pancreatitis is IV fluids, it's NPO, and then eventually within the first 24 to 48 hours, we try to give them enteral nutrition, and then we can do IV analgesics, right? They'll summarize it in one sentence. Treatment for acute pancreatitis. Yeah, you got a question.
Okay, yeah, let's just say supposedly you have like extra time on your hands. They let you out
Hmm?
of clinic early. You're doing questions and you see the educational objective. It's like treatment for acute pancreatitis.
Hmm?
Are there like actual content resources that you would recommend, like
Yep.
Amboss, to like read on so you can just like have a general overview to skim through if you're like, okay, I actually don't know anything about this. Like, what can I do to
Hmm?
figure this out? Or I haven't had a patient on it to look back at.
Yeah, I was gonna get to that in a second. Really good question. Um, really, like, so with regards to that, right? So you look at the educational objective, right? These educational objectives, whether it be from Amboss, UWorld, etc., they all come from the USMLE content outline. You guys can look this up on your own. It's free for the public to see. You just type in USMLE content outline. It's nothing fancy. They literally just say, here are the 250 concepts that could possibly be tested on USMLE. And it's like congestive heart failure, CKD, pancreatitis. You're like, wow, no shit. But that's where they pull all these educational objectives from. And really, so this is what I would do, right? Let me take a step back. And when you guys are approaching these questions, I've kind of taught you guys this. Read the last line first. What are they asking me? They're asking me, what's the management? What's the next step in management? I read the vignette. I try to come up with the diagnosis in my head, or at least point in the right direction, right? I'm like, okay, acute pancreatitis, they're asking me management. What I would like for you guys to try is try to predict the answer off the cuff, right? And again, like for a lot of these, your first pass through UWorld, Amboss, etc., you're gonna have no idea, and that's totally fine. What I want you to build towards is being able to predict these answers, right? By predicting the answer beforehand, you're testing, do I actually know this, right? If I can predict the answer, if I can read it, I'm like pancreatitis, treatment is boom. If I can do that, I know it. If I can't do it, but I know it's pancreatitis, I'm like, okay, there's a little disconnect. And if I don't even know it's pancreatitis, there's a big disconnect. The other reason this is good is, as you guys saw in your step 1 prep, there are going to be really tricky answer options, right? MBME, UWorld, Amboss are all really good at writing the wrong answer option to try to trick students. Not necessarily trick them, but like they know the wrong answer option students are going to pick, right? So by predicting the answer, finding the best answer that lines up, picking it, and just moving on, you're going to save yourself from switching answers and, getting tricked, okay? And last but not least, by predicting answer options, it will prepare you for real life, right? You guys are going to see, you're going to walk into the hospital tomorrow and they're going to say, hey, you go see this patient with abdominal pain with the intern, right? You think when you walk into the ED to evaluate this patient with abdominal pain, they're going to have an A through F over their head and you're going to be like, yeah, C sounds good, right? Yeah, let's do that. No, you guys are going to have to know history, how to take a good history, how to do a physical exam, what labs, imaging, etc. you want to do. It obviously takes time, but this prepares you. So going back to the question that was asked is, what do you do, right? Absolutely. Amboss articles, UWorld articles, first aid step 2. There's a book called Mastering the Boards that I think is really good. There's a book called Case Files for every clerkship rotation that are really good. You could watch a quick YouTube video or my personal favorite, ChatGPT or Open Evidence, right? ChatGPT and Open Evidence gives you like a really quick synopsis. And the new ChatGPT is very accurate, and it also is starting to cite sources. So yeah, let's say you get this patient on pancreatitis. You're like, I have no idea. You could definitely, if it's a UWorld or Amboss question, click on the associated article and read, right? You could screenshot the question, throw it into ChatGPT and have a conversation, treat it like it's a tutor, and continue to ask why. Like, hey, why do I give lactated ringers instead of normal saline in a patient with pancreatitis, right? Why do we favor that? You can ask the why. The more times you're able to ask why and understand reasoning behind things, the easier it is for you to conceptualize these concepts and be able to perform well on these exams in real life, okay? Or you could watch a quick YouTube video. Those are all really good things. Really, like the thing is like in real life, you can't just wait for the patient to present so you learn the diagnosis and the management. But what you're gonna see is UWorld, Amboss, and all these other like question banks are gonna cover the same concepts over and over and over again. So the beauty of it, you get this, your first ever question for step 2 UWorld is on the management of pancreatitis. You get it wrong, okay? You put into your own words why the right answer is right, why the wrong answers are wrong. You look at the educational objective. Maybe you've read an Amboss article. Maybe you've discussed with ChatGPT. You've got a little better understanding, okay? How much of that you read are you going to actually retain? Maybe just a little bit, okay? You're not expected to remember everything you read. The beauty of these question banks, with them being like 4,000 plus questions, is what are the odds they have another pancreatitis question in there? 100%, right? Pancreatitis is such a common like thing they like to test, and it's a common thing you'll see that there's probably like 10 to 15 questions in both question banks, right? So maybe in a week or a month, you'll get another pancreatitis question, right? You read the vignette, it'll be slightly different. You're like, this still sounds like pancreatitis. And then they'll approach the management or diagnosis or whatever they want to ask from a slightly different direction, and you'll get to test yourself again. And you'll just see it over and over and over again. So the hallmark of studying for step 2 is the consistency. It's making small little gains every day, right? Building towards that clinical excellence. I'm gonna like take a step back, and you're like, well, like Anki does the same thing, right? Like basically what I'm telling you is these question banks will do spaced repetition for you. It's not the traditional way where you have a set number of Anki cards every day. You go through your question banks, and there's going to be multiple questions on CKD, cirrhosis, heart failure, pancreatitis, and you're going to see them over and over and over again. Now, Anki surely has a place, right? Like step one, it definitely had a place for like bugs and drugs and some of those inheritance patterns and chromosomal translocations. Great. Those are things really you just have to rote memorize and move on. For step two, it is primarily, it's like 97% critical thinking. There are very few first order questions. Okay. Anki does a really good job with memorization. It does a really shitty job with overall critical thinking and understanding of these concepts. Um, Anki has a role where, let's say, you get this question on pancreatitis and you've seen it like 3 or 4 times now and you still don't know the management. Sure, put that on an Anki card, do it for a couple weeks, you'll never forget it, right? But if you are having the problem where you read the vignette and you're like, I don't even know what diagnosis this is. If you don't even know how to diagnose pancreatitis, me doing Anki cards on that is just putting a band-aid over the problem. Like, I need to take a step back. I need to read something, watch a video, discuss with ChatGPT. How do I diagnose pancreatitis, right? Like what is the illness script for pancreatitis? And then let's go over diagnosis and management. Um, so I think like the built-in space repetition of your question banks is going to be key, and it's going to force critical thinking, and that's how you're going to build this knowledge over time. With that, let me go into like how I studied for like step two in rotations, and that'll even more solidify it. So obviously, like your guys' curriculum is a little bit different. You don't have shelf exams. I think that's like it's such a bad idea. They'll probably eventually change it. But for now, you guys don't have shelf exams. Um, for us, like for every 4 and 8 week rotation, we had a shelf exam, and like that shelf exam was like 40 to 50% of our clinical grade. So like you need to do well on it, right? There's a big incentive for doing well. And so for me, I made sure for every rotation I did all the AMBOSS, all the UWorld. I redid my wrongs, and then I did these NBME CMS form questions for every rotation, and we'll talk about those CMS forms. I did those for every rotation before taking the shelf exam. So by the time it was time to take the shelf exam, I would have done like 5,000 plus questions for like every rotation, like in all honesty, plus doing ChatGPT questions, doing extra question banks, right? Like, so for your family med rotation, you'll get access to the AAFP questions. For OBGYN, you'll get access to like the ACOG questions and etc. Um, you could do the questions in the back of the case files book. You could do questions in the Mastering the Boards book. There's so many opportunities for questions outside of just like UWorld and Amboss. UWorld and Amboss obviously being like the gold standard. So, um, but so with that, right? I had like over 5,000 questions, and I was like, there's nothing they can ask me on these shelves that I haven't like covered. What question you got?
One question about UWorld, because they told us that we only get the subscription for a
Yep.
year. So they were saying like we shouldn't activate it for like another month. So then I was kind of confused as to what I would be doing now. And
Yeah.
like kind of along those lines, the I was just looking at Amboss, and I know there's like the regular Amboss questions like how you had us do last year. And then
Mhm.
they also had those study plans for clerkships. I don't
Mhm.
know if they pull from the same questions or if you like recommend one or the other.
Yeah. Yeah. And so I was like that was like gonna be my finishing point. Again, like great, you guys are reading my minds. With regards to like you guys not having shelf exams, I completely agree. There's nothing pressing for you guys where you have to activate your UWorld now. Because again, you only get it for 360 days. So if you're like, hey, I'll probably end up taking step two in January or February, yeah, maybe it's better to wait until like mid-February to activate UWorld. The Amboss will surely do the job, right? It'll start teaching you the concepts. The Amboss and UWorld ask very similar questions. I think UWorld asks more of the high yield concepts, and their questions tend to be just a little bit closer to the way MBME asks. Whereas Amboss, the Amboss questions to me seem a little bit harder than UWorld. And they ask some of the more nitty gritty details. So there is like doing both is better, right? And I'll get to that. But really, like since you guys don't have to do a shelf exam that counts for 50% of your grade in the next 4 to 8 weeks, there's no need to unsuspend or to activate UWorld now. You can get away with just doing Amboss for the next month or two and then slowly start adding in the UWorld. And with regards to the study plans, same questions. They'll be the exact same questions. The study plans just have like the built-in articles too. Um, So it's like, you're on psych. If you did like the psych study plan, it'll be like several, like, I don't even know how many. It'll be like several dozen psych articles, like high yield articles, plus the questions. The thing you have to realize is like how much time are you going to have to read all these things and do the questions, right? It's kind of like a give or take. Um, I never did the study plans. I just did the questions. And then if I had like a specific question or concept I needed or like didn't understand, then I would go read the specific article. If you're someone who's like, I don't even want to touch a question until I have my bearings, then read all the articles, do the study plan that they have. But in my opinion, like you can get away with just jumping right into the questions and learning from like trial by error. Um, but yeah, you guys don't have to do UWorld yet. Um, my big thing though is right. You see what I did, right? So it was UWorld plus Amboss and redoing my wrongs because I'm like, all right, my first month in OBGYN, I'm learning a completely different language, right? You're learning the fetal heart tracings, fetal station, all these random new things that you do not learn as an M1 and M2. Obviously, I'm going to get those questions wrong, so I want a second pass at them, right? Whenever I need more content, I go to ChatGPT. I'm like, hey, I'm studying for my USMLE OBGYN shelf exam. Can you write me a multiple choice question on this? Don't give me the answer, right? And then I can do a million questions. ChatGPT can ask me an infinite number of questions. The better I get, I can have ChatGPT start asking me open-ended vignettes, and I can work on my differential, my next steps, my management, my complications, and we can progress that way. Um, and you have access to in your big SIB folder, or for anyone else who's watching who doesn't go to MCW, you can find these online. They're called MBME CMS forms, Content Mastery Series. Okay, every rotation has X number of CMS. Like your IM and surgery, I think had like 7 or 8 of them. Family Med, I think there's only like 3 or 4. But what these are they're 50 question PDFs written by MBME or the USMLE. Um, and there's supposed to be the 50 highest yield concepts for each rotation. So if you think about like IM, right, there's going to be like between the 8 different forms, like there's going to be so many COPD, heart failure, cirrhosis questions, right? You're going to see it asked from different angles. You're going to see the questions asked in slightly different ways. And you're going to get to test yourself over and over and over again. So what I did for every rotation, finish UWorld, finish Amboss. Doesn't matter which one you start with, or if you do them both at the same time. I truly don't think it makes a difference. Redo your wrongs to kind of cement. Have ChatGPT fill in the blanks. Do a case files. Read that if you need to. Read whatever you want, and then like a week or two before the rotation ends, do all these CMS forms and see, okay, did anything actually stick, right? Also in these in your big SIB folder are going to be like old MBME exams that you can absolutely do whenever you want. Obviously, the further you are in your third year, the better you'll do at these exams. Because like if you've only done OBGYN, you might do really crappy on like the surgery questions or the IM questions, etc. Um, but key point for the long run, right? Since you guys don't have shelves, there's no pressing need to get anything done now. But I'm telling you, you need to do a little bit of everything, a little bit of something every day. And for what that really means is like I set my goal as like 10 questions every day. That it's such an easy thing to do, like 10 questions. Like after you guys have taken step one, you're like, oh, 10 questions, easy, right? I wake up in the morning, I can easily pop out 10 questions in like 15, 20 minutes max, right? Move on with my day. The beauty of it is like 10 questions is such a low threshold. Like throughout my day, I'm going to have more than enough time to get a few questions here, a few questions there, a few questions there. I go home for the day. I'm like, oh, I got 30 questions done, right? I tripled what I wanted to get done. It makes you feel good for the day, right? Um, when you're on surgery, maybe you only get 10 questions done, right? When you're on ambulatory, maybe you get like 80 to 100 done, right? On your days off, you might have, if you have like you're not burnt out, right? And you feel good, you could do 100 plus questions, right? And you eat into these. But what I'm getting at is like, unlike step one, like I don't treat step two like you have like this 4 week period where you're just going to grind everything out. I promise you, if you do a little bit every day and you consistently build into it, you don't need to do a dedicated period. you will be ready to take the exam in a year, right? Between your clinical rotations, seeing patients, and doing 10,000 plus questions, you will be more than ready. Um, and that would be my goal for you guys. I think for this group in particular, and really for most medical students, it is more than reasonable to at least get all of UWorld and all of AMBOSS done and redo your wrongs at least once, right? That right there would be over 10,000 questions. You have a whole year to do that, if not more, right? More than reasonable to get that done. If you had to, right, if you're like crunched for time for whatever reason, pick one question bank. I don't care, UWorld or Amboss. Either one's going to get it done. People tend to lean more towards UWorld. Pick one, be the best at it, and move on. But in all honesty, doing all of UWorld, all of Amboss, redoing wrongs, and doing those MBME CMS forms is going to be the biggest bang for your buck. Yeah, Alyssa, you had a question.
Okay, am I looking at the wrong thing because, or maybe this is right, like on the Amboss, I changed it to step 2, and for psych, there's only 179 questions. So like if that's the only bank that I have, I feel like I would get through that pretty quick.
Yeah. So like that sounds reasonable because I want to say like UWorld probably has around the same. It kind of depends how they put like different concepts and different questions because like at the end of the day, your step 2 exam on if you look online, it's like 60% IM. In all honesty, it's like 90+% IM. Because like really like psychiatric questions are internal medicine concepts. And really like the only non-IM questions are like very specific OBGYN questions like fetal heart tracings, for example, and like very specific diseases just to kids, right? Surgery, psych, family med, all that shit, it all stems from like medical principles, like medicine principles. So like some question banks will be weird and like you'll see IM has like a lot of psych content or like psych questions. For both Amboss and UWorld, IM, there's like 2,000 questions for your IM rotation. Um, so yeah, like if psych only has like 180, knock those out, redo your wrongs, and then jump to the next rotation, right? I've had students in the class above you who were like scared to like move ahead. I'm like, what are you scared about? Like, they're like, well, what if I forget? I'm like, no shit, you're gonna forget, right? How am I supposed to learn and remember 4,000 new concepts? You can't, right? That's the beauty of medicine. Like that's why I love internal medicine. It's like I'm learning something new every day and I'm remembering something I forgot every day. That's like the nature of medicine. But the further ahead you can get, the more time you're giving yourself on the back end to redo, right? And so this is the kind of like the last piece is when I got done with UWorld and Amboss for the first pass, right? So like I of course was doing it to the rhythm of my shelf exams, and I was always a step ahead. Like I finished my OBGYN stuff like halfway through, and then I jumped into surgery, which was my next one. Obviously, I was still doing some OBGYN content here and there, so I was ready for my shelf exam. But by the time I even stepped foot into the OR for the first time on my surgical rotation, I was like 3/4 of the way done with the UWorld surgery questions, right? So I was like always a step ahead. I ended up finishing UWorld and Amboss like around December, like my winter break time, and then I reset UWorld and I did that bitch again. Um, I don't expect anyone to do that, but I redid it and I did like all these MBME questions, all these ChatGPT, and then I ended up doing like over 20,000 questions. And that's why like when I was done, like I didn't need a 4 week period to sit down and just freaking like learn everything or like review everything. I was like, I've been reviewing everything for the last year. Like I'm ready to take this exam. And we'll kind of talk about like gauges to get it ready. But yeah, for like Alyssa, like who you only have 180 questions on Amboss, obviously you'll unsuspend or you'll activate UWorld at some point and you'll have X number of UWorld questions. But if you get done with 180 questions in like 2-3 weeks, you redo your wrong, whatever your next rotation is, jump right into that. Because you'll get a head start. And it will be beneficial. Yeah, so the big things if you guys are starting with IM, that might be the only time you're not able to finish all the questions for both UWorld and Amboss, right? Because that'll be like over 4,000 questions, which is probably hard to do while you're busy on rotation. But you just kind of got to think about it. I just need to get everything done by like next November or December, right? So if you're a little behind or a little ahead, it'll all like work out as long as you just stay consistent. Okay. And like with regards to that, right? You guys have the CRE and the CCSE exam. That'll be in like November or December of next year. So that's like your end goal is those two things plus step two, getting ready for those. But again, like doing your all of UWorld, all of Amboss, these MBME CMS forms, and then obviously like practice exams when you're ready. That's going to be the key. And then I think the last piece I want to talk about in terms of prep is using ChatGPT to help teach you like more advanced concepts. Okay. Because any student, right? I always give this example. Any student who is sitting for the step two exam, if I give you a vignette and it's screaming ischemic stroke, right? 70-year-old male, diabetes, smoking, hypertension, hyperlipidemia, presents at 2 hours after having left-sided facial weakness and left arm weakness, right? 100% of the students who are sitting for step two will tell me you need to get a non-contrast CT of the head, okay? So what do you think the odds are that MBME on step two will give you the exact same vignette and not say anything about the non-contrast CT and say what's the next step? The odds are pretty low, right? Because if 100% of people are going to get that right, what's the point of asking that question? Obviously, every now and then they do like slam dunk questions, and maybe that's the time they do a slam dunk, right? But in all honesty, they'll probably give you the exact same vignette. They'll say the non-contrast CT did not show hemorrhage, or they'll show you a picture of the CT, and then they'll say, what's the next best step? All right. So now I took a question where you had 100% of students could have answered it right. And now I make it a step further. And now maybe only 75% of the students can tell me, hey, if they present within 4.5 hours of having an ischemic stroke, I can give them a TPA or a thrombolytic, right? As long as they don't have any contraindications, which is a story for another day, right? But you can take a question that 100% get right to now maybe 3/4, okay? And then what if MBME tells you, okay, we get a non-contrast CT, no hemorrhage, and we already gave them TPA, okay? Now what do, right? Now, I take a question that like 75% could get right. I bring it down to like 25% could tell me we should do a CT angio of the head and the neck. We should look if there's any more clots. We should see if the patient is a candidate for surgical thrombectomy. And then we should start a statin. And then in 24 hours, we can potentially start aspirin and a P2Y12 inhibitor if indicated, right? So I can take a question that 100% of people can get right, and I can bring it down to like less than a quarter would get right just by asking next steps. So the reason I bring this up is because a lot of students study very superficially when it comes to step one and step two. They're really good at next steps and first line things, but they're really bad at like, okay, what if MBME throws a wrench into my vignette? Or in real life, right? What if the patient's not presenting like a textbook, right? Like you have to understand how to critically think on the fly and move around based on what MBME gives you and what your patient does, right? So with that being said, having ChatGPT write you open-ended vignettes might possibly be like the most like beneficial thing you could do once you guys kind of get your bearings, right? I wouldn't do this until I'm like several months into my third year because you guys don't know enough medicine. You guys are really good at pathophys and physiology, not good enough at diagnosis and management to like truly start building this. But same example, right? They give me a patient who's presenting with like ischemic stroke type symptoms and they leave it open-ended. ChatGPT leaves it open-ended. And I say, okay, this is sounding like an ischemic stroke. The pathophysiology is boom. The epidemiology is boom. I want to do this, this, and this next. If this happens, I'll do this. If this happens, I do this, right? And then you kind of go from there. And you kind of have ChatGPT grade you. And you're thinking through all the things. You could think about a differential diagnosis, right? You could think about all these different things, and you're building your clinical reasoning skills so you're able to master any kind of question the exam wants to present and any patient the exam wants to present. You can also do, I call it like the samurai method, where you're stuck on a concept. Like let's say it's lupus, right? You're like, man, I've gotten like 5 lupus questions wrong, right? I open up ChatGPT and I say, hey, I'm studying for USMLE step 2. Here is everything I know about lupus. I want you to correct me where I'm wrong and add in what I'm missing, right? And you just kind of brain dump, right? And you kind of see where are my holes, and then you kind of practice this every day, right? And I've said this before to you guys, but like you don't practice until you get it right. You practice until you can't get it wrong, right? That's what separates someone who scores a 240 from someone who scores, you know, a 270 plus, right? You're in the 99th percentile, right? And I think all of you guys are capable of scoring in that 270 plus range, right? Um, so those are some really key things. And then let's talk about real quick, like as you're getting closer to your exam, you start taking practice exams, right? So really what I would recommend for you guys at the MCW, like at MCW, since you have to do CRE, right? The clinical reasoning exam. I don't know how much they've told you about that. You'll basically, it's like a Qualtrics survey. They'll give you a vignette and then it's your job to order physical exam, labs, imaging, etc. And then based on that, they give you real-time feedback. Based on that, you make your assessment and plan. Okay. And then the CCSE is the exact same thing as CBSE. It's just for step 2. So with regards to that, I think it would be reasonable to take at least one step 2 practice exam before CCSE, right? Because CCSE counts for part of your clinical grade. I think you only needed to score like a 221, which is a pass, right? Anything like above like a 220, 221 is a pass. Once you've had a year of clinical rotations, and if you've done what I've told you and do all these questions and study the way I've told you, you will have no problem passing. But I think it's reasonable to do at least one practice exam before CCSE so you kind of see, okay, how does MBME ask about these stuff, right? You would have seen how MBME likes to ask about some stuff on your CMS forms, but it's always good to get a practice before, right? Go buy it off the MBME website, $60, sit down and do a time practice exam. But after that, CCSE will give you a really good benchmark. It's just like the CBSE and all your practice exams you took for step 1. It'll give you a score, and then it will say, hey, you have a 99% chance of passing step 2 if you took it tomorrow, okay? Your step 2 practice exams on MBME will give you a score, okay, and like a confidence interval. And so you can kind of base off of that. You guys should all have a score you want to aim for in your head when you're taking these exams. If you hit that score, I say just take the exam, right? If you're not where you want to be, more work needs to be done, and we can kind of meet you guys where you're at. But with regards to that, like as you're getting closer, you got to start identifying weaknesses, right? Right now, everything's going to be a weakness. You guys are going to read questions and you're like, what the hell is going on? I don't care about that now, right? Once you get through like 50% of a question bank, start looking at your score breakdown and you're like, like cardio, I'm scoring 80%, GI 80%. I'm really good at psych, but I suck at OBGYN. I'm like 20% on my OBGYN questions, right? OBGYN is a massive weakness. Go over, if you're like just doing UWorld, go over to Amboss and just do the OBGYN questions, right? Open up Amboss and read all the OBGYN articles. Talk with ChatGPT, have it write you questions, right? There's so many things you could do. But just by recognizing your weaknesses and starting to strengthen those, your whole score will go sky high. The problem a lot of students make is they love getting your 80%, 90% on UWorld and stuff when they're doing like the concepts they're good at. They hate getting 40% on blocks or 20%, right? On the stuff they're bad at. You got to lean into the stuff you're bad at. Do more and more questions, more and more content review of the stuff you're bad at, and your score will go up. And with regards to that, like studying your ethics and your stats and your quality improvement will also increase your score, right? Those are easy ways you guys can increase your score. But big point, recognizing weaknesses early will help improve everything. With regards to that, what questions do you guys have? I threw a lot at you.
I mean, I have like a question about psych specifically. I guess just like I'm a little bit nervous about what to expect with interviewing psych patients, like writing notes for psych patients and what if there's a different format or if it's really just like the same type of thing.
Yeah, let me this will kind of go for everyone. Whatever rotation you're on, talk with the senior resident, the fellow, the attending, whoever, and ask them for a template of a note, right? Like you guys all know how to write a SOAP note, but each attending resident, each field of medicine has like their own kind of specific spin on it. you're going to see your IM notes, super detailed, super long. Your surgical notes, super brief, right? Surgery is like patient sick or not, are they recovering or not? Boom, next. Your psych notes, super in depth, right? All about their subjective. So you ask your attending, can I use your template? Or you ask your senior resident. And if you guys aren't familiar with Epic, they'll show you. You can just steal their template and use it. This goes for any person watching this who's on any rotation. With regards to psych, you are by no means going to be interviewing patients on your own right off the bat. This goes for like every rotation. You guys are brand new phase 2 students. They're going to baby you at least for the first week. Okay. And then like eventually when you start feeling comfortable, you can start doing stuff on your own. But a lot of the times, like you'll go see a patient, you'll do whatever with an intern, a senior resident, the fellow, the attending, and they will teach you. That is the whole point of the rotation. Is they're going to teach you how do you do a psychiatric interview, right? They don't really teach you that in M1 year. You know, you kind of go over it, but you're like you just kind of nod your head. You're like, yeah, sure, whatever. But now you're going to get to experience it, and you'll get better at it, right? I mean, obviously, like psych can be pretty scary when you have like very unstable patients. And so if you ever feel, and this goes for every rotation, if you ever feel uncomfortable, you let your resident or your attending know. They will never make you do anything you're not comfortable with. Okay. That's the beauty of being a medical student is you can dip your toes into like literally whatever you want. You can get all the experiences you want, or you can get none of the experiences you want, right? It kind of depends on your how comfortable you are. But the beauty of it is you can have your say in patient management and care, but you are never responsible for the patient, right? So like I want you guys to try to be involved with as many patients as you can. Try to come up with assessment and plans, and it doesn't matter if you're right or wrong, right? The attending and the senior resident, that's their job to be right, and they'll push you in the right direction. But like with regards to psych, at least your first week, they're not going to have you do anything by yourself. You're inpatient, right? Like inpatient psych.
Yeah, I'm on consult.
Yeah. So like, oh, especially for consults, like basically what consult services are like an IM team, right? So like when a patient gets admitted to the hospital, the IM teams take over, right? And there's a number of house staff teams. And what a house staff team is it's interns, residents, and attending, and then medical students, right? All on one team. Whereas a hospitalist team is just one attending physician. There's no residents. So you might work in either teams. But when those teams, when they're like rounding on their patients, or they have a patient who might have a psychiatric problem and they don't know how to manage that patient or they want input, they'll call the consultant team, the psychiatric team, which would be you, your resident, your fellow, and the attending, and they'll say, hey, we have this patient they have a history of schizophrenia and they're on these drugs. They now have this new condition. Is it safe to keep them on their schizophrenia drugs, right? That's not a question like a lot of IM doctors might know. Psychiatrists will definitely know. And so you'll go and you'll interview the patient, you'll examine them, and then you'll give your formal recommendations to the IM team. So when you're on the consultant team, like it'll be your whole team will go and see the patient together. You might go like early with the senior resident, but you guys will all go together. So that's not something you'd have to do on your own. With regards to like surgery is always like a big one, right? Like especially if you don't have any interest in surgery, like I had no interest in surgery. Like you are not going to be doing the surgeries. You have probably learned how to maybe do a suture. At most, like you guys will probably at least the first week or two, you'll be holding the retractors, and then maybe if the surgeon likes you, you'll get to close some incision holes, right? As you progress, if you show like you're competent, and you show interest, maybe they'll let you do a little bit of the procedure. Same with like OBGYN, like unless you're like very comfortable and very vocal about like wanting to take part in like a pregnancy or like a birthing process, whether it be C-section or vaginal delivery, you'll probably be like standing in the corner and like maybe helping the attending or the fellow or the resident deliver the baby or the placenta or etc. With regards to like IM, family med, and peds, actually peds is a little separate, but like IM and family med, you'll be very involved in things. You'll have your patients for IM when you're on the wards. You'll have like they'll probably give you one patient you go and see like the first week or two. So you're not overwhelmed, but you'll pre-round on them, you'll talk to them, you'll do a physical, you'll write your note, and then you'll present them on rounds. That is your patient, right? You should know everything about that patient and beyond. The more comfortable you get, the more patients you can take on. But at least for your first week or two, I would only take one patient, right? One or two. You'll see as you get to like the sub-I and intern level, you can start taking like 5, 6, 7, 8 patients, right? And you'll see like your attendings and senior residents have to know all the patients, right? You just get better. Family med or like outpatient ambulatory, you're gonna basically, when you're on like inpatient, you have a lot of time to see the patient, think about the patient, make a beautiful presentation, think about all the mechanisms and everything's happening. For like your outpatient, your attending will let you go see the patient beforehand. Um, you'll probably have like 10, 15 minutes. You'll talk to them, you'll examine them, you'll come out, and the attending's sitting right there, and you're going to have to give them your assessment right on the fly. You don't have a lot of time to think about it, right? Because that's how outpatient medicine works. It's boom, 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 boom. And a lot of the times, right, the patient may call in to the nurse beforehand and say, hey, I need to be seen by the doc. I'm having this really bad abdominal pain. And so you'll see on like Epic, it'll say, the attending will say, hey, you're seeing the patient at 10 a.m. Read up on them, be ready to go see them. And you'll read and you'll see that the chief complaint is abdominal pain. That's what they told the nurse. You'll read all about them. You'll come up with an idea. You'll walk into the room and you'll say, hey, like, I hear you're having some bad abdominal pain. Tell me about that. And they're like, no, I'm not having abdominal pain anymore. I'm now having like 10 out of 10 crushing chest pain. It's radiating to my shoulder. And you're like, oh shit, right? It completely throws you off. So you'll get a lot of patients who are like, you could do prep beforehand and they'll completely have a different problem. So like outpatient really forces you to think rapidly on the fly, think about your physical exam and come up with an assessment really quick on the fly. You'll also get a lot of practice writing notes on outpatient. And then pediatrics is kind of a special one because obviously kids are a very like special population. As a medical student, especially like a phase 2 student, you'll have your patients that you get to go examine and stuff. They're probably not going to let you be too hands-on, especially like with the 1-month-olds and like some of those really small infants. And then what's the ED and anesthesia? It kind of depends on who you're with, what they let you do. The ED is obviously going to be very busy. Anesthesia, you might get a few intubations, a few IV placements and stuff like that. But overall, like at least your first week in general on rotations and probably your first week on any rotation, they're going to baby you. They're going to baby you until you show them that you're competent. And then they'll start giving you more freedom. I shit you not. Will never name names, anything like that. But I've been on rotations with people where like it's just like clear, like you need a little more time to learn the things you need to learn. And so you're gonna take a step back. And so it's like when you're on rotations with other medical students, like don't be afraid to like step in and like ask for more work, but also don't be like a gunner or like dick about it, right? Like you guys know how to walk the line. Um, but if you're like, hey, like the amount of work you're giving me is too easy, like I need more, ask for more, right? If the amount of work they're giving you is too much, tell them, hey, I need to take a step back, right? Help your fellow medical students out. And then probably the last thing I'll say is whenever your senior resident, fellow, or attending tells you to go, you go. You do not say, no, I'll wait, or like you don't second guess. When a physician tells you to leave, go home, you go home. Okay. They have been most senior residents and attendings are really cool. And when the day is like when the work for the day is done, there's no more learning opportunities. They will tell you to go home. You don't stay because if one of your other medical student leaves and you stay, it makes them look really bad. It also makes you look really bad. So if they tell you to go, go, and then do whatever you want with your free time. Study, go for a run. I don't really care. Just like when they tell you to go, go. I think that's probably like the biggest thing I learned because like I think my first rotation or two, it was so weird for them to tell us to like go. Like don't we have more to do? And they're like, no, just go home. So just go home. Because when you get into residency, you don't have the opportunity to go home. So use it as a medical student. What questions you guys got?
I have a quick question just about pre-rounding and what that looked
Yeah.
like for you. Because I'm on IM first and I'm with a hospitalist, not a house staff team, so it's really just me and the hospitalist.
Yeah.
And he emailed me and let me know that I needed to pre-round like every day this week, but I don't really know what he was looking for.
Yeah. Yeah. Pre-rounding is definitely a skill. And again, your hospitalist will probably be very chill this first week as you're getting used to it. Basically what pre-rounding is, did he give you like a patient to look at or like something like that?
Yeah, he told me he was going to assign me 2 at 7 a.m. tomorrow.
Okay. You 2 patients?
Mm-hmm.
Yeah. Okay. That'll be okay. Yeah. You can handle that, right? You 4, you can handle more than 1 patient. But in general, right? When if he hasn't given you a patient, there's nothing you can do now. If he gives you the patient at 7 a.m., which is usually what happens on IM, is like, hey, you come in from overnight. Your overnight team tells you, hey, we had 3 new admissions that came to your team, so you know nothing about these patients, right? So you kind of go in blind. The way I pre-round, everyone does like it slightly different. First thing I do is, if you know nothing about the patient, what is their chief complaint? Like, why are they coming in, right? Patient came in with concern for pulmonary embolism, right? Whatever. Let me just like at least orient myself. Then I look at their vitals overnight and now, right? Heart rate, respiratory rate, blood pressure, things along those lines. Were they stable or unstable? I then try to read the notes, especially the nursing notes. If I know the patient, I look at the nursing notes, because the nursing notes will tell me patient was comfortable overnight, no problems, or they'll tell me patient vomited 3 times, etc. Right, and I'm like, okay, that might be a problem. I might need to check on that. Then look at other notes, right? Like the ED will write a note. If any consultants were asked to come see the patient, like, hey, maybe the patient had a kidney problem and they called nephrology, and the nephrologist came, saw him, and wrote a note. Try to read the notes and kind of see what's been going up with the patient. Then what I do is I look at the labs and the imaging, right? So look at all their new labs from overnight and this morning. Look at their EKGs, their chest x-rays, right? Anything else they've gotten. And then I start putting my assessment together. It's exactly what we talked about. I'll send that note over, but you just do your problem based, okay? But pre-rounding is just getting yourself situated with the patient. So why are they there? What are their vitals? What are their labs? You can look at their old physical exams, and then look at the notes, like what has been done to this patient, what interventions. And then when you're rounding, you do the same thing, right? If it's a brand new patient, you got to tell your attending about what happened, like what brought them to the ED, what brought them to the hospital, right? You give them the HPI. Then you go over your objectives. You say patient was hemodynamically stable, he was afebrile, blah blah blah. You tell him your physical exam. My physical exam was normal, or he had an S3 sound when I auscultated his heart, right? Whatever. And then you give your assessment, right? My assessment is like a 1 or 2 liner, like patient presented with hypoxemia, dyspnea, tachycardia, tachypnea, recently started an OCP. The CTPA was concerning for pulmonary embolism, right? That's my assessment. Then I go into my plan, right? It's problem based. So like first problem would be chest pain, right? Chest pain, blah 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 blah. Overall concerning for PE, and then you say your plan. My plan is this, this, and this. Okay. You go to your next problem and your next problem and your next problem. Um, it's a conversation with your attending, and so they'll go back and forth with you. They'll ask you questions, not necessarily pimping you. They'll just ask you questions to like clarify things, right? Because the attending is looking for very specific things in a history to point them one way or the other, and etc. Right? They'll probably ask you questions, like pimping questions, but that's like the basics of it. Does that kind of help, or do you need more? Like what else can I help you with?
I think that makes sense. So essentially, like you're doing all your pre-study and then you go pre-round, just assuming like a couple hours before everyone else pre-rounds. So if you're doing an assessment on someone, let's say it was like severe abdominal pain, and you do a physical exam, they're probably not going to want to have a second physical exam by the physician. So are you limiting anything so the doctor can do it? You do everything, and if they do it again, it's kind of just like that happened.
You are the doctor. You are this patient's doctor, right? That should be your mindset.
Okay.
You are gonna you are going to pre-round on like 2 patients, and then you will go see all the patients with your attending, right? Same with house staff. It's the same idea. But you need to do your assessment and plan, right? How can I do an assessment if I can't even lay hands on the patient, right? I can't. Okay. I mean, I can't give you a good one. But yes, pre-rounding is you're coming up with the patient story, right? You're putting the story together, and you're coming up with this beautiful presentation on how this plus this plus this all makes me think of this, and I think we should do boom boom boom. That's what you're presenting. So your pre-rounding is doing whatever you need to get the full story, to orient in your head what I think is going on in this patient and what I think we should do next to help get them out of the hospital. Does that make sense? I think someone had a hand up, right?
Yeah.
Someone, yeah.
Yeah, so they talked a lot about during orientation that we have to wake patients up in the morning. Can
Yes.
you give us an example on how you would do that? Because I also have to pre-round this week, and if I'm coming in and the patient's sleeping, like, what's like the best way to approach that without getting yelled at by the patient?
Yeah. Okay. Yeah, I'll say like 80 to 90% of patients understand they're at a teaching hospital, and that medical students, interns, residents will be coming by quite early in the morning. And honestly, if you're on IM and you're not even on the surgery team, like the surgery teams, they will pre-round at like 5 a.m. If you're on like IM, you're not going to pre-round until like almost 7 a.m. at the earliest. So you won't even be the earliest person. And nurses oftentimes wake patients up in the middle of the night to get their vitals, to get labs, etc. So these patients are really used to getting woken up at random times. They understand they're in a hospital. They're not gonna get sleep. They're gonna get woken up multiple times. So often what I do, obviously knock on the door. First things first, look on the door and see if does a patient have any isolation or whatever, right? If they have a COVID or flu or respiratory virus, it might say airborne isolation, you wear a mask. If they have C. diff or concern for C. diff, you have to wear a full gown and a mask and gloves. If you don't know where those are, you ask one of the nurses. But oftentimes, if they have C. diff or a need for fully gown, all the gowns will be right next to their door. You knock, obviously hand sanitizer. You guys did ASCII a million times. But then I just say, hey, Mr. Smith, my name's Adam. I'm one of the third year medical students. I'm just here to kind of chat with you a little bit and check up on you, right? And they'll either be like, oh yeah, yeah, or they'll be like really grumpy and kind of pretend to go back to sleep or try to go back to sleep. But you are the doctor. You like obviously use your best judgment, but like you need to speak with the patient, right, in order to make your assessment and plan. So usually I'm a little pushy with them, and I say, hey, can I just like 5 minutes, and then you can go right back to sleep, right? Um, I know it's really awkward as a new student, like waking patients up. I always feel bad about it, but they understand, and you have to understand. Like I need to speak to the patient, right? It's in their best interest. Does that help? What else you guys got?
This is kind of a follow-up question, but like just to be clear, for pre-rounding, like you're really just getting the like HPI. You're not like going through like an OSCE type of thing where you're asking them all about the whole thing, or should you
So
do that too?
this is where it really depends on if the patient is brand new to you and your team, you better get a full HPI. Okay. Here, let me like give you a little like a quick story. Is like I learned this one the hard way. The ED, like because obviously like when you think about how things work, the patient presents to the ED or they were a direct admit sometimes from like an outpatient clinic, but vast majority of patients come through the ED. Your ED team does a really good job stabilizing the patient and deciding, hey, do they need to be admitted? And if they need to be admitted, should they go to the ICU or should they go to the regular floor? Or can we discharge them home, right? Um, in this case, they're like, let's admit them to the floor, right? The ED, especially at a place like Freighter, like an academic, like huge medical center, is super busy. And these ED physicians are amazing at recognizing does the patient is this a really big problem? They need to be admitted or not. They often don't have time to make like in-depth medical diagnoses, right? You guys will appreciate this when you're on the ED. But a lot of the times, they'll say, hey, like this patient has a concern for pneumonia. Let's admit them to the ED, or let's admit them to the floor, right? Really great job by the ED physicians, because they recognize the patient needs to be admitted. But I got burned last year where in the ED note they said like, hey, like big concern for pneumonia, we should treat them. And the overnight physician started treating with antibiotics, right? Um, and when I went to see the patient, like I kind of read the ED and the overnight physician's assessment, and I was just like, yeah, this is pneumonia. And so first thing when we went on rounds, I gave my assessment. I'm like, yeah, this patient has pneumonia. I think we should continue antibiotics. And the attending was like, why do you think this patient has pneumonia? I'm like, I couldn't give her an answer. I'm like, I just like literally like verbatim, like read what the ED and the overnight physician said. And she's like, there's not even an infiltrate on the chest x-ray. Like this isn't pneumonia. And so I looked really stupid because I just kind of like took what the ED and the overnight physician said. So my big thing for you, if it's a new patient, I always get their story from them. Like even if they've told it a million times, I do not care. I'm gonna ask if you want to do it OSCE style, do it OSCE style, right? OPQRST, get your history, past medical conditions, medications, etc. Whatever you need. I get the full story from them, and I try to never read the assessment from the ED or the overnight team or whatever. I try to make my own assessment. Um, so if it is a brand new patient to you and your team, get the full thing because you're going to have to tell your attending the full thing, right? If it is a patient, hey, this is your third day pre-rounding on them, you don't have to do full history. You already know about the patient. So when I go see that patient, it's my third time seeing them, or whatever. I just ask, hey, how are you doing this morning? How are you eating? You using the bathroom okay, right? Subjective, right? So my subjective is really quick, right? Patient rest was comfortable overnight. No acute events overnight. They're starting to increase the amount of food they're able to eat. They're able to use the bathroom more, etc. Does that kind of help? Yeah.
I
So,
had a follow-up question.
yep. Go ahead.
Okay, so let's say you have a brand new patient admitted to the hospital from ED. I looked at AMBOSS, like the basics to IM stuff, and they had a huge like ROS thing that you can go through. Obviously, like I know like if the patient's coming in with abdominal pain, like don't go through like GU stuff, but like to what extent like okay, not I meant neuro, but like okay,
Okay.
to what extent do you like actually like do everything? Because like if you're attending obviously would have more experience and like starts asking you about like endocrine questions like do they have like night sweats like things like that and you're like well shit like I didn't get this like ROS stuff like do
Mhm.
you just like say I didn't get it. Like how do you know like how do you learn then like
Mhm.
what ROS that you're actually supposed to get in this like subjective thing cuz looking at that list there's just so much that you could potentially ask them.
Yeah. Great question. So obviously, like, there's a million things you could ask. This is what I call hypothesis-driven, like medicine, right? Is like my patient comes in with X, Y, or Z. I observe them with my eyes. I do a physical exam, and I'm already starting to generate a differential in my head. Now, to be able to do that, you have to have a really good basis of medicine, right? You guys coming in as brand new phase 2 students aren't going to have that basis of medicine. Give yourself a year and you're going to have a better basis of medicine. Um, and that's how you understand what questions to ask or not, right? So you're going to watch, like your attending will speak to the patient, do maybe the same physical exam, and they'll ask a very set specific review of symptoms. Okay. Um, you're not going to be there, and it's totally fine if you miss stuff. That is why you're working with an attending, a senior resident, an intern, whatever, who's supposed to help you, right? Medicine is a team sport. So it's okay if they're like, hey, the attending says, hey, do they have night sweats? And you just go, I didn't ask, right? You be honest about it. The other big thing is like never lie. Don't be like, no, they don't have night sweats, right? Like if you didn't ask, you can't say that. That also goes for your physical exam. Is like if you didn't listen to the patient's lungs, do not put lungs clear to auscultation bilaterally. That's fucking stupid, right? You literally will get sued. Not you as the medical student, right? But like your note is like it's a legal document, right? So like if you write in there lung auscultation clear bilaterally, and they actually have like a pneumonia and the patient ends up dying, you will get sued. Okay. Someone will find that and you will get sued. So especially as a new medical student, like if you forget review of symptoms, that's totally fine. And then if the attending is like asking you questions, like as you're presenting, and you don't understand why, you literally pause and you say, wait, why does that matter? Right. And they will tell you. But in general, right, for IM, just kind of go head to toe. And like when you're brand new, you can literally ask all of these things. Okay. I like to go like head to toe. Any headaches, right? Any dizziness, right? Any loss of consciousness, any change in your vision. I go like mouth, any trouble swallowing, any problem speaking, any shortness of breath, right? You could talk about nose, any new bloody noses, any change in your hearing, right? Talking about neck, any new lymph nodes or masses you're feeling, right? We already talked about swallowing, any pain with swallowing. You move down a little bit, right? Any muscle pain in any of your body, right? Any joint pains, any new rashes. You go to your chest, any new chest pain, right? Any palpitations, your abdomen, any abdominal pain, any nausea, vomiting, um, any new diarrhea, constipation, bloody stools, right? Throwing up blood. Then you can kind of move down further. Any pain in your knees, right? Any trouble walking, any new sensation changes, right? There's a million questions you can ask. Um, the better you get at medicine, the better you get at putting the picture together. You can ask some very, very, very fine detailed questions to kind of key in. But for now, if you wanted to, you could totally print off that amboss sheet or have it on your phone, and you could just go down the list if you wanted to, right? If that makes you comfortable, and you'll get better at realizing what questions to ask. It might take you a year, it might take you 2 years, it might take you a million years, right? That's the beauty of medicine is like, you're if you're an attending and you don't think you have anything new to learn, you're not doing your job right. But yeah, the review of systems just takes a lot of practice. But what you guys should realize is you can make the vast majority of your diagnoses just based off of history and physical exam, right? Asking the right questions, doing the right exam, knowing what to look for, you can get the right diagnosis the vast majority of times. It just takes practice. What else?
Okay, I have a question about I started on ambulatory
Hmm?
and I have 2 days of clinic and that's it. So is there like some unspoken thing that I'm missing that I'm supposed to be doing?
No, so
Or
like your
yeah,
guys's your guys's curriculum is different. Because like when I was on Family Med, like it was 5 days a week, and I was there from like 7 a.m. to like 5 or 6 p.m. like most nights. Like they had me freaking working. Um, but yeah, for some reason for you guys, like it's limited time in the clinic, which I think hurts you guys, like because you're just gonna see less patients. Um, I heard for like Family Med, there's like other assignments. This goes for like all your rotations. Make sure you stay up on this. There will be like random assignments. Like for surgery, there was like a million videos I had to watch on like Brightspace. And I had some stuff here and there. There's like aquifer cases. There's sometimes you have to write papers and shit. It's like super stupid. But like hopefully no one from the MCW like affairs or whatever none of the deans watch this. But like I think most of it is like bullshit, like busy work. For Family Med, I want to say there's like aquifer cases you're gonna have to do, but for the most part, it's like free time, right? Like it's like do what you need to do to become better at being a medical student and physician. So with that free time, you have extra time to study, and you have extra time to do research projects or whatever, and just chill, right? Take advantage of this free time because like when you're on IM or you're on surgery, like you're gonna have less free time. There's no unspoken rule, right? Just go, show up, do the best you can when you're there, and when you're off, like do what you need to do, right? Um,
okay, makes
yeah, I don't
sense.
know why you guys have such limited clinic time, but it's gonna end up hurting you guys in the long run, but it'll be okay.
Okay, cool. Thanks.
Yep. What else? No other questions?
I have one more question.
Yeah.
We
Go
talked
ahead.
about what happens when you have a new patient, but what if you have a continuing patient but a new physician that's you're attending?
Yeah. So then you usually give them kind of like the brief hospital course. So this is why like really knowing your patients well, it's super important. So like, let's say this patient has been here for like 5 or 6 days, and then your attendings switch over at Freighter. They switch over on Mondays. So it's a brand new attending. You don't have to give them absolutely everything that occurred, but you're like, hey, this is a 56-year-old male with boom, boom, boom. He presented on this day for diabetic ketoacidosis. He was getting better. We were treating him with boom, boom, boom. But then he developed hospital-acquired pneumonia. We started ceftriaxone or blah, blah, blah. We started ceftriaxone actually wouldn't be a good option. We started Vanco and cefepime, and now he's getting better, right? And then you kind of give him the update of what's going on today. But really, like these attendings, they're going to get handoff from the other attending. So the attendings will know what's going on, right? And they do their own, like when an attending moves on to service, usually the day before, they're like stalking the chart and reading up on all these patients. But you should just pretend like the attending knows absolutely nothing about this patient. By doing that, like I pretend like my attending knows nothing about all my patients, because by doing that, it really helps me decipher, okay, what is the really important medical information that will help my attending make the best decisions, right? Like I don't need to tell them every single lab, right? You guys as brand new medical students, I guarantee you will sit there and you'll probably read off every single lab, and your attending is going to be like, don't tell me about the freaking chloride. I don't care about the chloride. That's like their classic. They hate chloride. And you're gonna tell them like all this imaging stuff, all this random stuff. But the better you get, you realize what's important and what's not. And what does my attending need in their back pocket in order to make the proper diagnosis and management. But yeah, you would give them kind of like the brief hospital course of what's going on. And the last thing we didn't talk about was like discharge summaries. If you guys are on the inpatient service, you'll be responsible for discharge summaries. Again, there's like a template for it, and you just kind of fill out the template. But that's kind of like an overall hospital course, and like kind of what happened to the patient and what does their PCP need to do for them once they're discharged, and then they go see their PCP, right? So you guys will get the hang of it. It just takes a lot of practice. It takes a lot of time. Anything else? So big things. Start Amboss as soon as possible. Just get consistent with it. In like a month or so, or whenever you want, activate UWorld, jam into that. Start adding in those MBME questions when you're getting ready to be done with the rotation. And then have conversations with ChatGPT. Use First Aid if you want. Use these other textbooks. Watch short videos. I think Anki has a limited use. If you're a big Anki fan, go ahead and use Anki, and you'll learn how much Anki you can do every day while also trying to do questions and be on rotations. And then when you're on rotations, right, try to be very present. Ask questions, understand the why. You guys will be great. I'm on like a weird block right now. It's called like Master Clinician, where I'm like in a different part of the hospital every day, doing like different physical exam stuff. But like next block, so I start in 2 weeks, I'll be on infectious disease consults. So if you guys are on like inpatient and you have like a patient with an infectious disease problem, like I'll be the team you call. So I might see you. And then the month after that, I'm on medical toxicology in the ED. So if you guys are rotating in the ED, I might see you guys. But I'll be around. So definitely text me, email, whatever. I'm also going to hold like step 2 lectures like I did for step 1. I want to give you guys like a month to like kind of get settled and get used to it. And then I'll hold these sessions on like different Saturdays, because Saturday tends to be like the best day, or maybe Thursday afternoon. We'll see. But I'll hold some of those, and I'll teach you guys like some clinical reasoning. No longer like I'll make them open-ended. We'll do physical exams. We'll do all this. I'll teach you how to think like a doctor. All right. That's what we're here for. All right. Anything else? All right. You guys are gonna kill it. Let me know how it goes. I'm excited for you guys. All right.
Cool. Thank
Thank
you.
you.
All right. See you guys.
Thanks, Adam.
Bye.
Yes.